Muito obrigado, excelente apresentação, professor Fábio. Agora, nós conseguimos, boa notícia, recuperar o vídeo do Dr. Richard Du, e então ele vai continuar a apresentação dele do relatório padronizado e Léxico, Experiência do Memorial Sloan Kettering Cancer Center.
Hi, my name is Richard Du. I'm an attending in the body imaging service in the Department of Radiology at Memorial Sloan Kettering Cancer Center. And today, I'm going to talk about standardized reporting and lexicon, the MSKCC experience. Now, why is it important to standardize our reports? I think Dr. Shinagari put it best in this article in 2019 in the Journal of the American College of Radiology. The radiology report is perhaps the single most important clinical output in a radiology practice, and yet it seems to be an underrepresented component of diagnostic radiology research and education. I'm going to go through a history of our efforts to improve reporting at Sloan Kettering, starting with, in 2009, the structured reporting template, in 2012, our certainty lexicon, followed by the change lexicon, numbering lexicon, and finally, the oncologic response lexicon. Prior to 2009, our reports were free-form text with a single paragraph often describing all the findings. Imagine how hard it is for clinicians to read through this entire paragraph to figure out what is important for that patient. Since July 2009, we have moved to the structured reporting template on the right. We separate findings by the organs in which they belong under individual headers, such as hepatobiliary, spleen, pancreas, adrenals, and so on. It is much easier for the clinician to look for the evidence behind our impression, to see where the disease is, and to see what changes occurred in which organ. There is no question that both radiologists and non-radiologists prefer structured reporting. We were also motivated to standardize our certainty lexicon based on this paper and others. In this table, you can see different terms that are used to describe levels of certainty, such as diagnostic of, consistent with, likely, probably, and possibly, and how they are interpreted by both radiologists and non-radiologists. When using a scale from 1 to 15 to describe most certain to least certain, you can see there is a very wide range of interpretation for these individual terms. Even when we say something is diagnostic of, the range can go from 1 to 8 for non-radiologists. To reduce this variability and ambiguity, we limited the number of words that are used to describe our certainty level. When we say something is consistent with, we are more than 90% certain about that possibility. We can use suspicious for or probable when we're about 75% sure, possible for 50%, less likely for 25%, and unlikely when we think something is less than 10% possible. This certainty lexicon is at the bottom of every report for both our clinicians and patients to see. In clinical trials, we use RECIST or response evaluation criteria in solid tumors. It is an evolution of the WHO criteria, which uses 2-dimension, while RECIST uses single largest dimension. However, most patients are not in clinical trials. And for the majority of our patients, we measure the lesions as follows. We always describe the lesion first, followed by the measurement, and if applicable, the prior measurement. We provide two-dimensional measurements, with the largest dimension always coming first. When there are multiple lesions, we like to describe measurements on individual lines so that it is easy to compare the current and prior state. Our oncologists prefer to see tables when it comes to cancer reporting. We don't quite use tables, but at least we put measurements on individual lines to make it more legible. We also limit the number of words that are used to describe interval changes. We use increase or decrease, followed by modifiers like marked or slight. And when nothing has changed, we use the word unchanged or no change. Notice that we do not say stable disease, which has a very specific meaning in RECIST. This article also illustrates the danger of ambiguity in wording when it comes to describing somebody with multiple lesions. One can use few, several, multiple, or numerous with different interpretations by the referring clinician. So we have limited the number of words used and what they mean. We use the words few when we mean there's 2 to 5 lesions, multiple for 6 to 20, and numerous for greater than 20. We avoid the term several and innumerable. Finally, we have standardized how we report oncologic response, and the details are in this article. Standardized reporting of oncologic response, making every report count in radiology imaging cancer. Similar to other RAD system, like LIRADS and BIRADS, we use a scale of 1 through 5 to describe decreased disease to increasing extent of disease. We also have 2 additional categories, ORM and ORE. ORM stands for mixed, or when there is both increase and decrease in extent of disease, sometimes within the same organ or in different organs. And this speaks to tumor heterogeneity in a cancer patient. We use ORE, or equivocal, when there are findings that suggest possible or probable increase in extent of disease, but the findings are not unequivocal for malignancy. By using standardized response lexicon, we can start measuring the rates of response or progression at scale. For example, in this sample of around 15,000 reports that were labeled with this lexicon, we can see that increase and decrease occur at around the same frequency, around 13 to 14%. Unchanged occurs about 19% of the time, and mixed is used very infrequently, only about 4% of the time. In summary, structured reporting and standardized terminology improves the clarity and quality of our reports. At MSKCC, we have standardized words that describe certainty, number, change, and oncologic response. We also provide guidelines for standardized measurements to improve the legibility of our reports. I would like to thank the Radiology Reporting Committee, Jean Teresi from the Response Committee, and especially Dr. Panisek and Dr. Risak, who were at the forefront of developing structured reporting and standardized lexicon for our department. Thank you so very much for your attention.